Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network and the UNC Lineberger Comprehensive Cancer Center. Thank you so much for being here today, November 15th, 2017, for our Medical and Surgical Oncology lecture. Let me go over a few preliminaries, a disclaimer statement, a few of those sorts of things, and then we can meet our presenter and start our lecture. So if you're having any trouble at all, email us, unccn@unc.edu, and we can address technical difficulties or any other problems related to this presentation today. You can also call us, and that's probably the best way to reach us right away, at 919-445-1000. Please, if there are any problems at all in terms of your receiving the today's show, let us know right away so that we can try to address those. We'll use poll everywhere in just a moment, and we'll talk about that shortly. We're on the web at unccn or just at unccn.org, so you can find us there, find us on Facebook, on Twitter, and on YouTube as well. All right, we're going to start off with a poll in just a moment, so let me show you that poll and show you how to connect to it, and then we'll see what you think, and this is all anonymous. So the question on the poll is, according to the Melanoma Research Foundation, nearly what percentage of melanomas are thought to be caused by exposure to UV light and sunlight? So take a look at that, and then you may know the answer or you may have a best guess, and you can, if you think that's 10%, you can let us know with an A, 30% B, 60% C, or 90% D. And the way you're going to do that is you can either go to pollev.com/UNCCN, and then you'll just find a web page and you can go ahead and answer it there. The way a lot of people answer this is with any phone that's capable of texting. If you'll text the number 22333, and then once you've entered that in, you'll send the letters UNCCN. So you're sending the letters UNCCN to the number 22333. Just one time you'll get a little message back. It will say join, and then you'll have joined the session. That will allow you to do the Q&A at the end and send us your questions. We hope that you'll be jotting down questions as throughout the presentation and then sending those in at the end. So go ahead and do for this particular poll right now, this first one, go ahead and send us your best guess. Again, A10 if you think it's 30%, send us a B, 60% a C, or 90% a D in terms of the percentage of melanomas thought to be caused by exposure to UV light and sunlight. All right. Our speaker today is Dr. Frances Colicchio, and she is a professor in the Division of Hematology Oncology at the School of Medicine at the University of North Carolina, Chapel Hill. Dr. Colicchio is also the American Society of Clinical Oncology representative to the Association of Subspecialty Professors of the Alliance of Academic Medicine. This organization determines policy and directs educational endeavors for internal medicine and medicine in general in the United States. She is past chair of the ASCO Oncology Training Program Committee and past chair of the in-training examination, which is used to help train fellows in the United States, Canada, Ireland, and other nations. Her academic mission is to advance training of physicians in the United States, particularly oncology trainees. Dr. Colicchio's clinical research mission is melanoma. She has been the principal investigator at UNC for more than 20 trials in melanoma. So we're going to go ahead and take a look at that poll, and we're also already getting those answers. While more of those come in, I want to say welcome, Dr. Colicchio.
Thank you very much, Tim.
Thank you so much for being here today.
Too. Yeah.
So just to remind our participants, these are anonymous, so make a guess if you like. While we're waiting for those to come in, what led to your interest and to being in the field of oncology?
Yeah, so when I was young, I would be walking through the hallway at Strong Memorial Hospital, Rochester, New York, and one of the residents said to me, "What are you doing?" I said, "I was doing oncology." He said, "You're very happy." And it was just that one little statement that made me realize that that's what I was going to do.
All right.
And that's what I did.
And that worked.
Yeah. And
yeah.
I got into melanoma kind of by chance back in 2003. There was no one doing melanoma work here
at
at
UNC at
yeah,
that time.
And
okay.
so I got to be here at a good time.
Well, we're fortunate to have you.
Thank you. Thank you.
Well, what do you think? We're trending at C 60%, and we've got about a third of our participants at 90%.
Well, I know the answers.
Yeah. Do you want to tell us now, or do you want to wait until further on in your presentation?
Oh, we can talk now. It was 90%. Actually, Tim and I were coached ahead of time. We were both kind of surprised it was that high.
Yeah.
Which makes us all want to put our sunblock on even today.
Absolutely.
Yeah.
Absolutely.
So, pretty high.
Well, thank you to everyone who's here with us today, and thank you in advance to those folks who will be viewing this as an enduring material at a later date. I do have a disclaimer to read, or a disclosure to read, and this is our disclosure statement. This activity is planned and implemented under the sole supervision of Thomas Shea, MD, the course director, in association with the Office of Continuing Professional Development. Thomas Shea, MD, consults for Spectrum Pharma and receives research support from Millennium, Otsuka, GSK, BMS, Novartis, and Seattle Genetics. CPD staff have no financial relationships with commercial interests. The speaker, Francis Colicchio, MD, consults for Amgen and receives research support from Roche, Incorporated, GSK, Novartis, Morphotech, Bristol Myers Squibb Company, and Vascular Biogenetics. And with that in mind, I will pass the gauntlet here over to you, and the mouse as well, and you're welcome to use that as a cursor pointer if that's helpful.
Okay, I'll probably put him right over there for now.
Sounds good.
Okay. We have a lot to cover today. I've given this lecture before. We cover sort of the A's to Z's on melanoma, and it's pretty well received, so I'm using that same format. But since there are so many new medications for melanoma, new treatment paradigms, there's a lot to cover. I don't know who's out there. I figure some of you all are nurses, some are doctors, some are pharmacists. I'm going to try to touch on interest for everybody. And we'll have a few cases so we can see it like a real live patient. The first bullet point is you've got to know how to recognize melanoma skin cancer, because still the best impact we can have is catching these things early. I'm going to show you how you can stage the patients, and then by having the patients staged, you'll be able to figure out how to treat them. We're going to touch on the side effects of melanoma therapies. Those side effects transcend all of what we're doing in oncology now. And for the seasoned melanoma docs, they'll start to pick up what's new. So what's new? I'm going to go ahead and tell you what's new now, and I'll fold it into the talk. In 2018, January 2018, new staging will be presented. The sentinel lymph node surgery and completion lymph node surgery is undergoing revision. There's new treatment for stage 3 melanoma. There are new paradigms for stage 4 melanoma, and there's new paradigms for treatment of melanoma brain metastasis. Okay, so I have young adult children, and I was so happy to see that finally for the people under age 50, the incidence of melanoma is going down since 2012. And I think that might be in part because fewer teenagers are using the tanning beds. But for those of us over 50, the incidence continues to climb. The arrows are pointing to the men on the top and the women in the middle who are still getting melanoma at an alarming rate. So what's melanoma? Today we're discussing melanoma of the skin. You can get melanoma from any pigment cell, so you can get it from the mucosa of your mouth. For women, in the vagina, you can get it from mucosa in the head and neck area. You can get it in your eye. But we're not talking about that today. We're talking about melanoma from the skin. So the cutout shows us a picture of the skin, just to remind us all of the many layers of the skin. And on the right side of the slide, pay attention to the green cell. The green cell is to represent a melanocyte. And within the melanocyte is an organelle called the melanosome. And that's where poisons or sunlight can activate the melanosome, which can then turn the melanocyte into something that could become cancer. The steps that it goes through is in this cartoon. First, there is a melanoma on the surface of the skin, which, as I said, if you catch it very early, you could have an impact on curing the patient. The melanoma gets bigger, and it can travel through that green tube, which is meant to be a lymphatic vessel, or, which many people forget, it can go by way of the bloodstream. Things that predict whether the melanoma will spread are the thickness of the tumor, whether it's ulcerated, and how fast it's growing. Let's look at that word ulceration again. That does not refer to the patient picking at it, but rather the blood supply of the tumor itself. Okay, let's just go into our first case. Our first case is a 49-year-old married father of two who presents because his wife told him that there's a mole on his leg that's changing. He's in good health and he takes no medication, and there's the picture of the mole. So just look at that for a little bit. This is classic teaching. We know it well. ABCDE. Is the mole asymmetric? Does it have an irregular border? What color is it? What's the diameter? And has it changed? I should have put some calipers on this. This is a 4-millimeter mole, so not too big, but it changed, and that's the letter E, which I find as a melanoma doctor the most important to me, because my patients have already had melanoma. So if they say, hey, this one has changed, it prompts a biopsy. So here's our risk factors for melanoma. People who have increased nevi are at risk. People with fair skin are at risk. People with red hair, blue eyes are at risk. One of the most stunning statistics I heard is that the red-haired, green-eyed people have a 20 times increased risk of melanoma than the rest of the population. So there's a family that kindly donated their photograph to us many years ago. And at the bottom, here's another pearl you might take home today. If you do a family history and you find out that the family has family members with pancreatic cancer, that's a family that might need to have genetic counseling. Because for the other families that have had moles and melanoma, they've got to go see a dermatologist anyway. But the ones who have pancreatic cancer might want to send to the genetic counseling team. Okay, so back to our case. The nice man goes to the dermatologist and has his tumor biopsied, and this turns out to be a superficial spreading melanoma with a Breslow depth of 1.8 millimeter, and ulceration is present. The dermatologist refers the patient to the surgical oncologist to get the rest of the margins cleared and to consider a procedure called a sentinel lymph node biopsy. And here's a cartoon showing the sentinel lymph node procedure. On the right screen, you can see the person, and you can see that this person has a tumor on the right shin. You would not know if the lymph nodes went behind his knee or to his groin unless you did a sentinel lymph node procedure. Let's pretend for a second that there's another patient who has a tumor in the middle of the abdomen skin, that is. You wouldn't know if those lymph nodes went to the groin or to the armpit. So that is the beauty of this procedure. Through the injection of blue dye and radioactive tracer, the surgeon can find the lymph node basin. Once that lymph node basin is found, the sentinel lymph nodes are identified and removed. So this is what happens in our case. The lymph nodes were removed, and they go through sectioning. Rather than just a regular H&E stain, the pathologist is going to spend a lot of time to determine whether there are any melanoma cells within the lymph node. So this patient's sentinel lymph node procedure tells the surgeon that the lymph nodes that are at risk are in the right groin. He finds 2 sentinel lymph nodes there. They're sent to pathology. And 2 of these nodes, both of the nodes, contained melanoma cells. One of them had at least 1 millimeter of cells. Okay, so we have to talk about a new trial called MSTL2, which is modifying how we approach the next step. In this study, there were 1,939 patients randomized to receive either a completion lymph node dissection or observation. The observation group is required to come and see the expert team every 4 months and have an ultrasound for 2 years, and then every 6 months until year 5. The treated group obviously gets the completion lymph node dissection. This is a slide I want you to pay attention to just the right-hand part of the slide. Go to the top right, and what you'll see is that in the group that receives the observation, then they will have fewer local recurrences compared to the group that is observed. And that's also borne out on the bottom right. But what the study also showed was there was no impact on cure from doing the completion lymph node procedure. The take-homes are a decreased risk of local recurrence and improved staging with a completion lymph node dissection. But remember, the other group is getting ultrasounds by experts at frequent intervals. So back to our case. Our patient and his surgeon choose to have a completion lymph node dissection. And when this is done, the additional lymph nodes that are removed from him were 0 for 13. This means he had 2 out of 15 lymph nodes involved with melanoma. Okay. The next step is to figure out what his stage is. I've been doing this for 14 years now, and every time I go to the NCCN website or up to date and double check my staging. And you'll need to do that in January 2018 for sure, since it's going to change. Here's some of the highlights. There's a new T0 stage, which refers to that there's no primary melanoma seen. That's good because we see that a lot. The T1 category is further refined, and that will help the surgeons decide who should get the sentinel lymph nodes in the first place. There's a new C category to help tell about in-transit disease and satellites. And this one I think is really important, is a new category for melanoma brain metastasis. So let's take our patient. He turns out to have a T2B, N2A, M0, or stage 3B melanoma. Okay, let's talk about some biology a little bit. This is a really important slide. On the top is listed a whole bunch of cancers. On the far right, you can see melanomas on the far right. On the y-axis, it talks about the number of antigens that are abnormal. You can see that melanoma has the greatest number of antigens that are abnormal. That is one of the reasons why the immune system can see melanoma, whereas the immune system cannot see a lot of other cancers. Let's talk about some more things. So in this cartoon, we are fortunate to have numerous cells in our body that are constantly doing surveillance so that we don't all get cancers after age 50. That's our innate immune system. On the right side are the cells that we try to teach. We give them antigens so they can learn. And then these cells become CD4 positive T cells or CD8 positive T cells. And in the middle, we have interferons that help train both sides. So back in 2010-ish is when ipilimumab hit everyone in oncology's radar. This was huge. I was sitting up front at the annual meeting, and this was a sea change for oncology because this was the first immune therapy drug that was successful without being too toxic. And basically what happens is that our bodies are set up for T cells to memorize that we have cancer. But if we do that all the time, we'll all develop lupus, rheumatoid arthritis, Sjogren's syndrome, some kind of autoimmune disease. So we've naturally turned this off with a compound called CTLA-4. Ipilimumab blocks CTLA-4. So when you block that, you turn your immune system back on. There's the block. One more slide before we go back to the case. So think about, in melanoma, think about the immune system in two ways. One is that there's stuff going on around the body, the priming phase. The spleen, the liver, the bone marrow. These are things that are getting set up to teach the body what to do at the tumor. And the tumor is the effector phase. And that's where we have the PD-1 and the PD-L1. That's where pembrolizumab or Keytruda, that's where nivolumab or Opdivo are doing their work. There's some arrows. We didn't have arrows on this other one too. Okay, final one, sorry, there's one more basic. This is a classic slide too. And this is showing that within the cancer cell, there are these proteins, the RAS, RAF, MEK, ERK pathway, which we've learned so much about, which we can also use to block, to kill cancers. If you double block the RAS, RAF pathway, you not only get a more efficacious treatment, but you actually get fewer side effects than if you singly block this pathway. Okay, so our patient with his stage 3 melanoma has all these new choices for his treatment right now. He could be observed. There's a chance that he's cured. He's had melanoma surgery, the margins are clear. He could be observed. Come back at frequent intervals, report symptoms, have cross-sectional imaging. NCCN guidelines will tell you how often the cross-sectional imaging should take place. The patient could take interferon alpha. He could take nivolumab. He could take high-dose ipilimumab. He could take target therapy. That's 5 choices now. He chooses not to take high-dose ipilimumab. He chooses not to take target therapy. Down to 3. I'll go through why in just a minute. Okay. So if you go to nccn.org, you'll find the follow-up for melanoma. I'm always checking that too. I just want to make sure, because I used to get a lot of blood tests on these people. I don't get them very often anymore. You can see there's a great deal of variation on how often you should get the scans. So I refer to that website a lot. Here is the classic curve for adjuvant interferon alpha from a trial called ECOG 1684. This means that this study was done in 1984. It was the 16th study of that year. There's been many years of follow-up. This is now a survival curve. And the red line are the people that were treated with interferon, and the blue line were the people that were observed. You can see that there's very little difference between interferon and observation. And interferon causes a lot of side effects, so most people will decline. Here's the new stuff. Without my glasses, I'm not doing as well with this one, Tim. So I'll slip these on. Yes. This one was published online on September 12th and then published in print today. This is Dr. Weber's study comparing ipilimumab and nivolumab for stage 3B or 3C melanoma. And this ipilimumab is the high-dose ipilimumab. It has a lot of side effects. About 50% of the patients will develop a grade 3 or 4 toxicity, which could wind up in the hospital. Whereas with the nivolumab, it's 20%. Now, these curves are relapse-free survival, recurrence-free survival. We don't have overall survival yet on this data because it's new. So in the patient we're talking to, we must let him know that it's still rather early data, and that's why observation is also an okay choice. The patient chooses nivolumab, and authorization is sent to the insurance company for approval. Okay. Got their next case. Now we have a 55-year-old who was treated for stage 3 melanoma 3 years ago. He presents for routine follow-up, points out a lump under the skin of his right upper arm that had been growing for 3 weeks. A CT PET shows uptake in multiple nodules in the lung. A brain MRI and serum laboratory tests are normal. A lung biopsy is done and it shows recurrent melanoma. An IHC stain is positive for BRAF V600E mutation. At our place, we always prove it when our patients have a recurrent advanced melanoma. So I'm really glad in case 2 if the patient had a lung biopsy. This is huge. So I joined the melanoma program in 2003, and there wasn't really any treatment then. Temodar and IL-2. Now it's 2017, almost 18. Look at this. The median survival for stage 4 melanoma is 33 months. That's average. I mean, some people are living a lot longer than that. And look at this. 30% of patients might be cured with stage 4 melanoma. Stage 4 melanoma might be cured. Surgery still has a role in our stage 4 melanoma patients, and radiation is essential to palliate symptomatic sites and to help us when our patients develop brain metastasis. Here's another really important study. Again, I'm putting my glasses on so I make sure I give you the right dates. Yes. This is Dr. Wolchuk from 2017. This is the study that you probably have heard of, where it is nivolumab plus ipilimumab, or nivolumab, or ipilimumab. And you guys can see that the progression-free survival is higher for nivolumab plus ipilimumab and nivolumab versus ipilimumab. For overall survival, nivolumab plus ipilimumab and nivolumab are better than ipilimumab. But this study was not powered to compare nivolumab plus ipilimumab versus nivolumab. So we don't know for individual patients whether you need 2 drugs or 1. Okay, let's not forget interleukin-2. Interleukin-2 still has a place. It's tough. This is the treatment that the patient needs to go to the intensive care unit. At our place, Dr. Moskos approves all of the therapy, approves all of the doses along with the ICU physicians. It still has a place because it has a very long plateau on the survival curve, so we think we cure some people who receive interleukin-2. So what are we going to do for this guy? A ton of options. We can give him immune therapy or target therapy. We can give him combination of immune therapy and target therapy. Please note I left chemotherapy off this slide. It does not have a role in first-line treatment of stage 4 melanoma anymore. For immune therapy, it's my generally preferred option, although for patients who have very small amount of disease, a low LDH, and good performance status, they can do very well with target therapy too. As I said, I don't know if the patient should receive combination versus single. We'll go through that a little bit. I don't know if they should receive a combination versus sequential immune therapy. There are new immune agents coming about. We are looking at biomarkers as a way of helping us to determine who should receive what when. And there needs to be caution if the patient comes to you and already has an autoimmune disease, as the immune therapy could make their underlying disease worse. For target therapy, obviously you must hit the target. So the patient needs to have the BRAF V600E or V600K mutation. We're holding off on sending our patients' tumors off for complex sequencing until we're ready for additional treatments because their disease might change over time. But you're aware that there's many other targets that we could hit. Generally speaking, target therapy works faster than immune therapy. And generally speaking, it can be difficult to stop. But there are patients in whom you can stop. This patient and his doctor decided to take pembrolizumab as a single agent. I made this slide up a few years ago. It's one of my favorite. Just so you can see at a glance that the main organ sites that are affected by pembrolizumab and nivolumab, the PD-1s and the PD-L1s. It's about 20% of patients will have grade 3 toxicity, but it could be any organ site. Mainly the thyroid, the lung, the colon, the pituitary gland, the liver, and the kidney. But it could be any body, any part of the body can become inflamed. Okay, so our patient takes pembrolizumab. He's 3 months into the treatment. He's feeling well, has no side effects, but a scan shows that the tumors in his liver and his right psoas muscle have gotten worse. His therapy's changed to ipilimumab. You're probably wondering, does the patient have pseudoprogression? And that's when the disease gets worse, but it's not really worse. Pseudoprogression is very rare with the PD-1 inhibitors. This patient has true progression and he's placed on ipilimumab. So it's difficult to know whether the patients should have simultaneous or sequential therapy. Here's what I found for a retrospective study of patients who had disease progression after PD-1. There were 47 patients in this retrospective study. 37 were treated with ipilimumab and nivolumab upfront. The response rate for ipilimumab was only 16%, and it was 21% for the combination. 1-year overall survival was 54% for ipi and 55% for the combination. And there's your reference. I think the slides that I added weren't included, so I'll just basically say that if you take the response rate of your PD-1s, which is about 40%, and your response rate of ipilimumab, which is 15%, and you add it, you'll get 55%. So is it possible that you could sequence them and you'll still get 55%? This is what everybody is studying right now. Here's the cartoon I made for ipilimumab. Please note that there's fewer organ systems that I put up on this slide because that's true. It doesn't seem to inflame as many parts of the body, but boy, when the inflammation comes, it's much more likely to have the grade 3-4 toxicity. The main sites to know are skin, colon, liver, and pituitary. The colon is the one we fear the most. The colitis lands people into the hospital. You have to be very careful with management with ipilimumab. And new over the last couple of years is, especially with high-dose ipilimumab or with the combination of ipi and a PD-1, is you can get inflammation of the heart, which can cause myocarditis. And here's a picture of the colon of a patient who has colitis. On the biopsy, you can see these crypts of inflammation. It can be a little bit difficult to distinguish from C. diff colitis. So you have to take the clinical picture in mind, and you often will have to check for C. diff as well. Okay. So the patient has had his pembrolizumab, then he has his ipilimumab. He's getting tired, comes back, he has pain in his right neck. His serum LDH is 3 times upper limit of normal, and now he's getting more tired, so his ECOG performance status has dropped to 2. What do we do? Remember, this guy had the V600E mutation, so we discussed the BRAF/MEK inhibitors with him and his wife, and they choose this treatment. You need to give the doublets. You can't give these things single, so it can be dabrafenib and trametinib, or vemurafenib and cobimetinib. Those are your choices. They're very similar. The efficacy is very similar. I choose these based on the patient's lifestyle and some of the comorbidities. Dabrafenib and trametinib causes fever, more fever than vemurafenib and cobimetinib. Causes a lot of arthralgia. You have to keep trametinib cold, and these have to be taken on an empty stomach. Vemcobi, for short, causes a lot of skin toxicity. There's a slight increased risk in cardiac events, rhabdomyolysis. This does not need refrigeration. There's no food interaction. Both doublets can affect really any body part. They can be incredibly well tolerated, but they can also have serious side effects, so you have to watch out. This is interesting. New is the warning with pembrolizumab and nivolumab that cases of Stevens-Johnson's have occurred. I've seen this mostly when it's sequenced. So when my patients have been on immune therapy and then they go on BRAF/MEK inhibitor, or the other way around, we have seen some incredible rash. A little bit of rash is normal, and this picture shows a gentleman who's got a rather mild rash. Stevens-Johnson's, as you know, is like a burn reaction to the skin. So just be careful with that sequence. We're on case 3. I added case 3 because a few years ago when I gave this lecture, one of my colleagues said, "Hey Fran, why didn't you talk about your research?" So here's case 3 because this is my research. This is a 72-year-old gentleman who was diagnosed with myasthenia gravis, and then he developed in-transit melanoma. This is his left side body, and those blackish, purplish lesions that you see are his in-transit melanoma. Literally took about 3 weeks to grow all that disease on his chest. We were quite worried. Well, this is back in 2009, and we had no treatments for melanoma yet. Ipilimumab wasn't born yet. And Dr. Coffin came to me, he's from England, and convinced me to go for T, and convinced me to give T-VEC, which is a live virus herpes simplex construct. It works to destroy the cancer cell, and it also has GM-CSF tagged at the end of it, so it augments the immune system. This is how it works. First, you inject it into the cancer cells. Then the cancer cells lyse. Their proteins are exposed to the immune system. Then the rest, some T cells come, dendritic cells are formed. There's further attack at the site where you've given the drug, as well as in tumors in other places in the body. When the tumor is above the skin, we can give all the injections in clinic. When it's below the skin or in critical areas of the body, we use our colleagues in ultrasound to inject it under ultrasound guidance. There's our patient. There's another case where I could feel the tumor in this gentleman's neck. It's awful close to pretty critical structures. So we did that under ultrasound. As we were treating this gentleman, the tumors became softer and softer. The purple color continued. We kept going. Many months later, we took biopsies of these purple areas. There was no melanoma within them. They were just macrophages that still had pigment. About 3 years later, all the pigment disappeared. The patient's still doing well. He was treated, I believe, in 2010 or 11. Going through this fast because I want to leave time for questions. Case 4. Case 4 reminds us that we really need to do a lot of research. This is a 31-year-old engineer who was treated with interferon in the adjuvant setting. 3 months into therapy, a routine chest CT scan showed 3 new pulmonary nodules in the left lower lobe. I thought it was going to be sarcoid-like findings, but no, this turned out to be metastasis in her lung. Molecular cytogenetics were positive for the mutation of V600E BRAF. After she recovered from surgery, there was a scan of her brain. There was further disease progression in her lungs. She was placed on pembrolizumab. Before she even got the second cycle, she told me that her head was hurting her when she leaned down, and that's a snapshot of her brain. You can all see the numerous brain metastases that she was diagnosed with. The treatment of melanoma brain metastasis is rapidly evolving. You should know that half the patients who have stage 4 melanoma will also have brain metastasis. So we in melanoma get very comfortable with dealing with brain metastasis and their consequences. CyberKnife treatment is probably the best form of radiation that the patients can get. It's focused to the tumor. It spares healthy parts of the brain. And while melanoma is a relatively radio-resistant tumor, CyberKnife allows you to give a higher dose where you need to give it. But the changing paradigm is that some patients can be treated with systemic therapy up front. Our patient was symptomatic, so we did not treat her with, we considered using radiation up front, but there were so many tumors that we actually did use systemic therapy up front. So we've done a lot of talking in the last little bit, and as I said, I want time for questions. And what I've said so far is that there's a new staging system in January 2018. We've refined the T stage to include unknown primary site. We added C so we can further clarify who has in-transit disease. We added M1D to delineate melanoma when it has metastasized to the brain. For nodal disease, we're doing sentinel lymph nodes for most patients. And for completion lymph node dissection, it's still the best option for local control and staging. If the patient and the practitioner choose not to do completion lymph node dissection, then to be sure, they should have ultrasounds every 4 months for 2 years, and then every 6 months to year 5. Stage 3 has completely flipped. Since the online presentation in September, and then today's actual presentation, we can now recommend nivolumab in the adjuvant setting. And we could recommend it because it's effective with very few side effects. But patients have to know that the data is new, and we're not certain that it's going to impact their survival. They can choose observation interferon nivolumab or even high-dose ipilimumab after the balanced discussion. Stage 4 melanoma is undergoing a lot of research. We're not sure we should give combination ipi-nivo, ipi-pembro, single agent sequences? Do we give triplet therapy, ipi-nivo plus target therapy? Or are we using ipi-TVAC, ipi-pembro? There's a lot of options. It's basically a sea of riches. And for brain metastasis, it's evolving quickly too. Can we use systemic therapy up front, especially for the asymptomatic patient? Our research is focusing on treatment failure after checkpoint inhibitors, triple therapy for targetable tumors, brain metastasis, and smart combinations and sequences based on biomarkers and radiographic correlates. I want to thank you all for listening. Susie Worley's been with me since 2003. She said just call her, 984-974-8289. She'll get your patients in. Thank you.
Dr. Colicchio, thank you very much. We
Thank
really
you, Tim.
appreciate
Yeah.
that. So now is the time for our question and answer period. So let me just remind folks that if you didn't already join, you can join by texting to the number 22333, the letters UNCCN. If you already did that and joined for the poll at the beginning, then you're ready to go ahead and start submitting those questions. I want to say a special welcome to our friends at Rex East Raleigh. I see them out there, and give a wave of acknowledgement to them. They're a new site that's just joined us for the first time today. So thank you all for being here over there at Rex East Raleigh. We're glad to have you on board and look forward to seeing you at additional lectures as well. And of course, we want to say thank you to all of our audience members. We'll hope those questions come in. I had a question. You to start us off, you mentioned some of the success of the decrease in use of tanning beds, and I know there's been legislation to go along with that. Where is your hope for some other public health strategies that may show further decreases in melanoma?
Oh, I hadn't thought about it in terms of public health. I think this opportunity was good.
Good.
Just reminding ourselves that really going back to the basics, the ABCDEs, and as practitioners, we should all be checking everybody's skin. Have them take their clothes off and look at their skin. So we could do that. I think targeting at the high school and college level would be very good. I'm gratified that when I ride the bus home, I no longer see tanning bed ads on the bus.
Yeah.
I think they're catching on.
Good. Well, we've got questions coming in. Potential for CAR T therapy is our first question.
Oh, that's a great question. Yeah, the CAR Ts are fun. I just reviewed a protocol for the leukemia group that's doing CAR Ts. And one of the other hats I wear is I work with Dr. Simon Huggy in the brain tumor program, and he's developing a CAR T for glioblastoma multiforme. I think for melanoma, we're just I think we probably need to explore these compounds first. There are other accelerators of the immune system, a CD40 compound that could be used. The IDO inhibitors could be used. I touched briefly on TVAC or Imlygic with ipilimumab. That publication just came out. So honestly, I think I'd let the CAR Ts continue to dwell in those other areas and get further refined on the side effects before we bring them into melanoma. That's my opinion.
Great, thank you. Another question, is there a role for post-op radiotherapy in nodal mets that are isolated like the first case?
It's a tough question. We run these by Dr. Chira all the time. Our group has decided that when there's extranodal spread in the lymph node, if it's gone through the covering of the node, then their local recurrence risk is higher. And so for patients who have that spread, the idea of doing radiation is more likely. Where we will avoid it often is in the groin, because the risk of edema of the leg is so high. So we usually do it with the axillary nodal disease, and in the head and neck where local recurrence is so high.
All right. And another question, why is mitotic rate no longer used?
Oh, that's right. In the 2018, mitotic rate was eliminated. I don't know. I thought about that too. I was reviewing the literature and wondering. If I had to speculate, it might be because it was a hard thing to standardize amongst the pathologists. Years back, it was like a continuous scale, and then it went to mitotic rate greater than 1 or less than 1. So I'm not exactly sure. I wasn't in on those conversations.
Okay. And highest UV exposure risk in childhood with a question mark?
Yeah, I think that's where we really need to help is the kids, right? It's those sunburns that you get when you're young that is most damaging. So UVB for burn. We don't want our children to get burned. Exactly how to quantify that, I've read that you don't want more than 4 burns before you're 16. I don't think anybody truly knows. Look at the skin type. If they're a fair person, 1 burn might be enough to increase their risk. If they're the redhead, green-eyed person, that might be enough risk. So be very careful with the kids.
All right. And with regards to difficulty stopping targeted therapies, is this because of rapid relapse or other reasons?
Yeah.
And what are some of the drawbacks to drugs that, and I'm going to guess that next word would have been target. I know we've got a cutoff, so if you have a few more words you want to add in there, you go ahead and text us a second text if you would, please.
Yeah, I used to be really steadfast on this. I used to say, I have to use immune therapy first because if I use target therapy first, I can't stop this. And this was partly because I empirically saw a lot of patients that I would give the target therapy and stop, and the disease just went. And we basically thought we had done something to P10, which is a tumor suppressor gene. And that's probably true for a lot of people. If you turn off the tumor suppressor gene, the cancer can grow very fast. But there's a very important trial through the NCI that Dr. Atkins is the principal investigator of. And in this trial, the patients will start out with immune therapy, ipi-nivo, versus target therapy, dabrafenib, trametinib. And then when their cancer gets worse, they cross over to the other side. Until that study is done, we're going to speculate case by case on who needs to start what. I have a few patients now that I was able to stop the target therapy and put immune therapy on, or stop the target therapy completely. Mm-hmm.
All right. We have just another minute or so. If you have any other questions you'd like to share with Dr. Colicchio, I'll ask a basic one. Well, from the beginning of the lecture, you mentioned ulcerations, and then you mentioned not the kind that result from picking at the lesion. Is that a risk factor? Actually irritating? So we'll get that out of the way here.
Yeah,
okay.
no. Yeah, because how many dermatologists have told me that they saw people and the patient was so scared because they'd been picking.
Okay.
And they said, did I spread it? No, it's inherent to the tumor. But don't pick at it.
All right.
Go see the dermatologist.
Don't do it, nevertheless. But that's not. So we've debunked a myth there.
Yeah.
Okay, great. Well, that looks like it on questions. So I do have some important information to relay before we finish up here. We are so excited about our new learning portal at learn.unccn.org, and for years now, we've had members of our audience saying, "Gosh, I'd love to have attended that lecture and gotten professional credit for it, but I just couldn't be available on noon on a Wednesday, and that for whatever reasons we understand how busy everyone is." Well, we now, with our portal, you can see this lecture, see other lectures as recorded materials, take a test, fill out an evaluation, and get credit and get those certificates anytime within 1 year of the lecture. So this is what we call enduring materials, and we do have these available now. So learn.unccn.org, free and open access to 4 credit oncology courses based on recordings of our live telehealth lectures, anytime access to earned certificates of all credit from all UNCCN activities, and new live lecture evaluation process. New processes for completing lecture evaluation and receiving credit, and this relates even to today. The evaluation and opportunity to claim credit for participation will remain open for 7 days. Participants our designated UNCCN viewing sites. See your site coordinator for instructions. So if you're at a site, you can talk to your site coordinator and she or he can provide you with additional instructions. They've all been trained. GoToWebinar participants will receive an email 1 hour after the conclusion of the lecture that contains information and a link to step-by-step instructions for completing the evaluation and claiming the certificate of credit. And participants wanting CME credit need to follow this process as well. So CME certificates immediately are available after completion of the lecture evaluation. So this is some new material for and some new information for our live participants today. All right, if you have questions or problems, you can reach us at 919-445-1000 or email us at unccn@unc.edu. We always have more lectures, and our next one is November 17th. That's our community lunch and learn lecture at noon. What is immunotherapy and why is it so exciting for cancer treatment? And that's with Dr. Thomas Shea. On December 6th, we have our RN and Allied Health lecture, The Evidence Base for Integrative Approaches to Cancer Care with Dr. Gary Asher. And then on December 13th, our Medical and Surgical Oncology lecture, Metastatic Breast Cancer 2017 with Dr. Claire Dees. These are all going to be great lectures, and we do hope you'll be able to join us for those. Finally, a special lecture, Oral Cancer, a comprehensive overview with Drs. Patel, Dr. Hackman, Dr. Padilla. You can find out more information about that, unccn.org/oral cancer. And we will have, in addition to CNE, CME, and ASRT, we'll have ADA, Dental Continuing Education Credit. So we hope you'll be able to join us for that as well. We want to thank the North Carolina General Assembly for their generous support of the University Cancer Research Fund. We want to thank the UNC Lineberger Comprehensive Cancer Center. We want to thank Mary King, Veneranda Obure, and Alan Brown for all of their hard work to make these happen. And finally, thank you again, Dr.
Thank you very
We
much.
really
It was a lot of
appreciate
fun.
this.
Yes.
This has been great.
Okay.
All right, until next time, have a great afternoon, great rest of your week. We hope that you have a relaxing Thanksgiving, and we'll see you at our next lecture. Thanks so much.